Hello and welcome. I'm Fernando, a GP in the UK. Today we're looking at the NICE updates published in February 2025, focusing on what is relevant in primary care only. In today's episode, we'll be covering updates in smoking cessation, breast cancer and ovarian cancer. Right, let's jump into it. Let's start with smoking cessation and management for everyone aged 12 and over. The latest evidence review includes new guidance on Cytisinicline. But before moving forward, what is Cytisinicline? Cytisinicline, also called cytisin, is a plant-derived substance used as a smoking cessation aid. It is similar in structure to nicotine and acts as a partial agonist of nicotinic receptors. Cytisinicline or cytisin has been used in Eastern Europe for decades, and now it has gained interest here too. It has a dual mechanism of action, one by reducing nicotine withdrawal symptoms by mildly stimulating the nicotinic receptors, and the other by competing with nicotine for the receptors, reducing the pleasurable effects of smoking and decreasing craving. Compared to varenicline or Champix, cytisinicline has a shorter half-life, about 4.8 hours, meaning that it needs more frequent dosing, initially every 2 hours, but gradually reducing in frequency until stopped. Most side effects are mild to moderate and tend to occur early in treatment. These include gastrointestinal effects like nausea, vomiting, dry mouth and dyspepsia, and neurological like headache, sleep disturbances, fatigue and irritability. Cytisinicline should not be used during pregnancy and breastfeeding, as safety is not well established, for people aged 66 and over, in severe cardiovascular disease, with a caution in patients with arrhythmias, unstable angina or uncontrolled hypertension, primarily because of a rare but potential side effect of mild increases in blood pressure and heart rate. And it should not be used in severe psychiatric conditions either, such as untreated major depression or schizophrenia, though evidence is still emerging. We should avoid concurrent use with nicotine replacement therapy products, as cytisinicline already occupies nicotinic receptors, and combining with nicotine replacement therapies may increase side effects. Equally, combination with other smoking cessation drugs like varenicline and bupropion is not recommended due to overlapping mechanisms. So NICE has reviewed the evidence for cytisinicline, leading to new and updated stop smoking interventions. Let's have a look at them. A variety of interventions are available, including behavioral support, medicinally licensed products, and nicotine-containing e-cigarettes. Behavioral support may include individual or group support, as well as very brief advice. Medicinally licensed products include cytisinicline, varenicline, and bupropion, as well as short and long-acting nicotine replacement therapy. Another option is the use of nicotine-containing e-cigarettes. And finally, we also have the Alan Carr's Easy Way seminar, which involves elements of CBT and relaxation exercises. Cytisinicline, varenicline, and bupropion should not be offered to people under 18 during pregnancy or while breastfeeding. For young people aged 12 and over who are smoking and dependent on tobacco, nicotine replacement therapy should be considered alongside behavioral support. When combined with behavioral support, all these interventions are more likely to be effective. However, interventions less likely to be effective, even when combined with behavioral support, include bupropion, short-acting nicotine replacement therapy used alone, and long-acting nicotine replacement therapy also when used alone. We will give cytisinicline, varenicline, bupropion, and nicotine replacement therapy before the stop smoking. In terms of timing of prescribing, bupropion should be given with a quit date set within the first 2 weeks of treatment. For cytisinicline, the quit date should be within the first 5 days of treatment. Nicotine replacement therapy should start the day before the quit date. And varenicline should begin with a quit date set between the first 1 to 2 weeks of treatment. To support smoking cessation in primary care, we will offer to measure patients' exhaled carbon monoxide levels at each contact. These measurements can serve as motivation to quit smoking and provide feedback on progress. Some medicines are affected by smoking or stopping smoking in terms of their metabolism, efficacy, and adverse effects. This includes medications such as clozapine, olanzapine, theophylline, and warfarin. Therefore, we should monitor these drugs when smoking habits change, adjusting the dose as needed. We will advise people that stopping smoking in one go is the best approach. However, for patients who are not ready to quit smoking in one step, we will discuss harm reduction strategies. Cutting down or temporarily abstaining from smoking with or without the use of nicotine replacement therapy can be beneficial. We will reassure patients that medicinally licensed nicotine-containing products are a safe and effective way to reduce tobacco consumption, increasing the likelihood of quitting in the long term, and also helping to prevent compensatory smoking. Examples of compensatory smoking is inhaling more deeply or smoking more of each cigarette to compensate for smoking fewer cigarettes. And let's also quickly cover the use of smokeless tobacco, which is any product containing tobacco that is placed in the mouth or nose but not burned. It is typically used in England by people of South Asian family origin. For people using smokeless tobacco, we will inform them of the associated health risks, including cardiovascular disease, oropharyngeal cancers, and periodontal disease. A brief intervention should be used and advising to stop. In terms of preventing relapse, we will discuss coping strategies and practical ways to avoid returning to smoking at each contact. If needed, we will offer a further course of varenicline, nicotine replacement therapy, or bupropion to prevent relapse. However, as of February 2025, this remains an off-label use of bupropion. Now let's move to the next clinical area, breast cancer, focusing on updated recommendations for identifying, managing, and reducing the risk of lymphedema. This update applies to both early and advanced breast cancer. Patients undergoing breast cancer treatment should be informed about the risk of developing lymphedema. This includes explaining that there's no consistent evidence linking an increased risk of lymphedema to air travel, travel to hot countries, manicures, hot tubs, or sports injuries. Similarly, there's no consistent evidence suggesting that medical procedures such as blood tests, injections, intravenous medicines, or blood pressure measurement on the treated side increase the risk of lymphedema. Patients should also be informed that physical activity may improve their overall quality of life and that there is no indication that exercise causes or worsens lymphedema. Importantly, compression therapy should not be offered as a preventative measure, but only as active treatment. If lymphedema does develop, we will ensure that patients are referred to a specialist lymphedema service for assessment and discussion of management options. Once lymphedema is diagnosed, we will address underlying factors such as nodal disease or cellulitis. Compression therapy should be the first-line treatment, and if compression therapy is not suitable or comfortable, patients may wish to consider kinesiology tape as an alternative. The third and final area refers to ovarian cancer. There is an updated quality standard on ovarian cancer which states that adults with a total lifetime risk of 5% or more of developing ovarian cancer should have a discussion about risk-reducing surgery. This 5% risk threshold is calculated based on either a strong family history of ovarian cancer or a specific pathogenic variant. And let's have a look at some definitions. A strong family history is defined as having one or more close relatives, such as a grandmother, mother, sister, or daughter on the same side of the family with ovarian cancer. In these cases, referral to genetic services should be considered. These services should then assess the risk of developing ovarian cancer and discuss potential interventions. Risk-reducing surgery may include bilateral salpingo-oophorectomy, removing both fallopian tubes and ovaries, but another option is a hysterectomy with bilateral salpingo-oophorectomy, which also reduces the risk of endometrial cancer. So that is it, a review of the NICE updates relevant to primary care. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidance. You must always use your clinical judgment. Thank you for watching, and goodbye.